So this is supported by a grant of the WSB RAC. These are my collaborators on the grant. Jason, David is a statistician. Yumi and Harold are were responsible for getting a lot of the data together. René Louise France, Andrea Forlan over there, Ben Amick, and Sheila. You probably all know what the Institute for Work and Health is. If you don't know exactly, I'll talk about that later then. This probably fits in the second tier of our response to two broad domains about the recovery of injured workers through research and treatment, return to work, etc. So this is about prognosis. So prognosis is meant to predict the course or outcome of a disease process. It can either be predictive or explanatory, so either just purely aimed at getting the best prediction of a certain outcome, or explanatory, where you're trying to explain how the process goes. So this study is focused on having a predictive aim. So clinicians often use prognostic information to either educate patients or identify target groups for treatment, or to target specific factors to be modified through intervention. And it's considered to be a good starting point for communicating prognosis and reassure patients. Often patients have this feeling that their outcomes are really bad, and often by identifying the prognostic factors that determine outcome, people can actually get reassured and get a little bit of an overview of what's going to happen to them in the future and what their outcome is going to be like. So what's a prediction rule? So what we're trying to do is identify the best combination of signs, symptoms, and other findings in predicting the probability of a specific outcome. It's often used in medical research, so we've tried to take it a little bit further, because we're not only looking at clinical or medical signs, we also try to involve other factors, because they're better at determining work-related outcomes. It's not just about the medical signs and symptoms, it's all about how the workplace behaves and so forth. So it's based on the most parsimonious model. So we're trying to get as simple as possible, but not simpler, because it's supposed to be a tool that's going to be used in practice. So we don't want to end up with a model that has 45 variables in it, or 45 items from a questionnaire in it, because that's not very feasible for somebody that wants to use it in practice. So we want to get down to a very simple tool. And what I hear from my colleagues is that 10 would be great, 10 questions would be great. So we'll see what happens in this study. Clinicians often have difficulty in estimating risks of disease and outcomes. I think we all do. It's very difficult to see in the future. If we would all be very good at looking into the future, we would probably all be working in the stock market and making a lot of money. But these prediction rules, so they can be used to actually individualize treatment decision making. So instead of a one-size-fits-all, you could try to look at different approaches for different patients. In general, there are 3 steps in the development of a prediction rule. So first, identify the factors with the best predictive power. In our case, we did that based on a systematic review I did in the past for my PhD, and we updated through a grant we got from the Workers' Comp Board in Manitoba. Then next you want to validate it, establish the strength of the evidence and the reproducibility of the accuracy. So do previous findings actually hold in the setting that you're interested in? And in a perfect world, and it has happened, you would also want to look at the impact such a rule has. So having that knowledge, so when a clinician has that knowledge, does it actually change practice and improve the outcomes, or for instance reduce costs in that setting? So we aim to. So what In this project, we aim to assess the prognosis and identify high-risk patients who should be the focus of intervention, and by developing a tool to predict time until end of benefits and recurrences of bad benefits in workers with low back pain. There are a few studies that actually looked at end of benefits. There are not that many studies that actually looked at recurrences of benefits. And our target audience would be those that are active in work disability prevention. So what we did, we looked at the information that's available within the first 4 weeks of work disability. What often happens is that all the information available is used in a study. So in some studies they actually used information that wasn't available at the first time of assessment. So they actually use information that's only available, for instance, 6 months into the process, where a work disability prevention professional gets a file at, like here in Ontario, at four weeks, at least that they're aiming to see the file at 4 weeks. So you can our view is that you can only use the information that's available at that particular time point, because otherwise you're cheating. So at first we selected over 6,000 workers that fit our criteria. These were off work for 1 day. The date of injury was between January 1st and June 30th, 2005. It's 2005 because we used 3 sources of data. So we used data that's available at the WSIB, so that's readily available in the claim file. We used data that's available at the WSIB, but that needed to be transformed or data entered. There's a lot of forms available at the WSIB that are only available in scanned form, so you can see them at the terminal, but it's like a PDF or so it's a scanned form. It's not readily available in a statistical database or something like that. So that's what we did. We data entered a whole lot of data for these cases. And finally, we also used data that was available from the Readiness for Return to Work cohort to see if more scientific questionnaires would actually improve the model that we built. And that's why we used the time frame that we used, because the Readiness for Return to Work cohort was available data, but the data was collected in 2005. In the end, we decided to focus on over 1,400 workers that were still on full benefits at 4 weeks. So that's the time point where the WSIB case manager opens the file and sees what the next step should be. And we aim to predict outcomes at 6 months and over 2 years, and try to develop the most parsimonious or the simplest model possible, but not any simpler, of course. So the variables that we selected were based on the literature, so we didn't just put everything in our computer and press enter and let the computer decide what happened. So we only selected those variables where we had where we had an expectation that it might actually do something in a prognostic model. So what we used is we used Cox regression for time on benefits in the first episode for those still on full benefits at 4 weeks, and we used it for time until recurrence for those that returned to work after that time frame. So we first tested the factors that we selected univariately, and we moved those factors forward that had a p-value smaller than 0.2. We used the backward selection method to select factors. We also did that because that's the method used if we take the second step of the next step where we do internal validation of the model. So we're actually trying to look at the strength of the model by means of bootstrapping, which is a statistical method where you slice up your data, in this case 200 times, and you see in how many of those you check in how many of those slices your vector actually stays in the statistical model that you're developing. And we retained those vectors that would be in 50% of those slices, and that's a way to get a more robust estimate. That it's actually easier. The consensus is that it's more generalizable to other settings and time frames. So it's not dependent on your particular data set, but it's probably better applicable to other settings. We can always find a statistical significant association between X and Y. So for we're interested in the overall model, and we want to know how well that model actually fits our data. So we used a model fit statistic known as C statistic, or which is the same as the area under the curve between the risk score that we developed and the outcomes at 6 months and 2 years. It's often done in logistic regression. We also used it for Cox regression, and apparently that people don't do that very often. So it's in that sense we're innovating. We used upfront we declared that we wanted to have a certain standard, and often this is the classification that's used. So a fit of 0.9 that ranges from 0.9 to 1 would be considered excellent. 0.8 to 0.9 would be considered good. 0.7 to 0.8 fair. 0.6 to 0.7 poor. And 0.5 to 0.6 would mean a fail, because it's just as good as flipping a coin. So we're not really interested. We can't predict anything beyond flipping a coin. That's not very interesting. It's not really worth the effort. So here are some descriptors for the time that our sample was on benefit. So 50% of our sample was on full benefits for 57 days. So 31.8% was still on full benefits at 3 months, 15% at 6 months, 8.7% at 12 months. Yeah.
Can you remind me, is this just in the 1442 who were off work at 4 weeks?
Yeah.
Okay.
So this is the sample, the 1400 cases. So and at 2 years, 6.6% was still on benefits, so that's 95 workers that beats that. So these are the descriptives for time until recurrence. So because we already saw that 95 workers were on benefits for the entire follow-up, there were 1,347 that were at risk for recurrence, because those 95 hadn't returned to work, so they weren't at risk for recurrence either, because you have to get back to work to get a recurrence. So there's 1,347 people in our sample that were at risk for a recurrence during follow-up. So 11.9% experienced a recurrence within the 30 days after ending their first episode. 19% had it within 3 months after ending their first episode. 21% after 6 months after their ending their first episode. So it's a little bit of a moving time frame, because some of them are off work for a long period of time and then return to work and then have a recurrence, and some of them are off work in their first episode for a short period of time, and then it takes a certain time before they actually have a recurrence again. So I'm saying that 24.6% had a recurrence after ending their first episode at 2 years. So the good news is that actually 75% didn't have a recurrence in that time. So I think that's important to address. It's a lot of people don't actually have a recurrence as far as we follow them up.
What's your definition for recurrence again? Do they have to put in another claim to workers' compensation?
No.
Any benefits in that
It would be a reactivation of their benefits under the same claim number.
So it would have to be an official reactivation, so no official recurrences. Which is
Yeah. Yeah, it's purely based on benefit data. Considered a whole bunch of variables, and some of them were supported by good evidence, and some of them we were not totally sure about. Some of them we included because there's a strong feeling of having to include them. So there's moderate evidence for no effect of previous lost time claim and previous non-lost time claim. But if you would ask anyone, they would probably say, well, I would look into it anyway. So we considered it. We looked at these factors because they're often mentioned by people. So gross earnings, language, work-relatedness, and whether the employer actually expresses a doubt whether it's work-related or not. Being a union member, there's always a big debate going on. There's not. If you look at the acute phase, there's not a lot of evidence there, but just because there's no evidence doesn't mean that it's not possible. So the absence of evidence, you heard the quote, could actually, there's a lot of debate going on, so we thought it would be useful to actually look at it. So there's a strong evidence for the effect of an early return to work program, which is in the forms it's asked to the employer, and the question is, do you have modified duties available, and do you have a return to work program at your company? So recovery expectations is considered to have a strong effect on recovery limitations. It's very difficult to actually find that information in the forms because it's not. It's a very. It's not a validated questionnaire that's being used, so it's a little bit of a proxy that we use. There's some evidence about of the effect of medication that's prescribed on return to work, whether return to work is discussed by the healthcare provider, the role of whether the employer actually keeps paying salaries. There's strong evidence that physical demands matter in return to work, and these are all things we measured because the type of healthcare provider and the type of treatment that people get is considered to be important. So that's why we considered it in our model. So this is a messy table. So in the end, job tenure didn't matter. As expected, previous claim didn't matter. Gross earnings didn't matter. Language didn't matter. So so that means that either the WSP does a really good job in getting people official translators or interpreters, or people are really reluctant in actually reporting which language they consider to be their first language, because what we found is that actually very few people report that they don't speak English. So, but in the end, in the model, if you use that data for your prognosis, it doesn't show up. So in the end, what we did find was that age matters. So the older people are, the slower they get back to work. Gender doesn't matter, but it was in the model anyway because that's what we do. We adjust for gender. Union membership mattered, and where there's a debate where people say, well, unions delay people getting back to work. What we actually found is that people that report that they are union members actually get back to work faster. This is
Yvonne, could you just pause there just for a second? I'm just looking at the proportion of beneficiaries who reported they were and were not union members.
Mm-hmm.
So it's about 50-50.
Yeah.
Which seems to me it's a bit high in terms of union representation. for Ontario. It's not that it's wrong. I'm just getting a sense of the sample.
Sure. I mean, there aren't that, the workforce isn't divided 50-50, but maybe people who make claims are divided.
Maybe 50, okay. So thank you. I just wanted to...
And it's people that are out for at least 4 weeks.
as well.
Where it might actually be 50-50. So it is our sample, and that might be different from the general population. So doubt work relatedness, this finding is a bit odd because it was retained in the model because it showed up in more than 50% of our bootstrap samples. So it improved our predictive model, but you don't really see it in the effect estimate. So that's how they do it with building a prediction rule. It has to improve the model, but the effect estimate might not really show that like that in the final overall model. So on an individual basis, it would actually make a difference. Yeah.
And that's the employer who doubts the work relatedness.
Yeah. So the employer reports. Yeah.
Sorry, is that because there's a synergy between doubt work relatedness and some other variable that
Could be.
Yeah, so what the idea is that it might involve litigation or adversarial process, or so they actually report that so the employer is asked whether he thinks it's work related or not, and he can say yes or no and maybe.
But individually it doesn't make a difference, but it makes a difference in terms of the composite.
I think you're right that the flip-flop of the significance and the importance in different models may have something to do with how it plays with other variables, I would guess. Yeah?
Yeah.
That's what you were asking, right? Yeah.
Yeah. So the early return to work, having an early return to work program is quite interesting because if you don't have it, it actually means that people are away from work longer. When we presented it to our stakeholder group, they said, yeah, but that's because the larger companies, it's only the larger companies that have that in place. So I went back and checked that, and actually there are quite a few smaller workplaces, so below 50 or smaller, that actually report that they do have modified duties and a return to work program in place for their employees. And there's also quite a number of larger workplaces that report that they don't have workplace accommodations in place. So, yeah.
Was firm size at all been considered in the model?
Yeah, it was considered, especially after getting that response. So, from the if you look in the literature, firm size doesn't show up as being a prognostic factor. But after getting that question from our stakeholders, I decided to go back in and see whether replacing this variable by workplace size, for instance, whether that would make a difference. Well, workplace size didn't show up as being predictive. And when I cross-tabled it and actually showed that some small workplaces actually report that they do have modified duties and return to work program, and some larger companies actually report that they don't have it. Maybe for that particular case, or maybe in general, but they report. They're being honest about it.
How about things like industry and stuff? Is that all in the physical demands? Is that the right?
I think that in the end that ends up in the physical demands because that's a classification that is derived from occupational codes.
Just remind me what the source of information is for the declaration that a workplace does or doesn't have.
It's the employer.
So it's on the employer's form. Is it a simple yes, no?
Yes, no.
So we don't know the quality of a yes or the quality of
No.
it hasn't been verified. It's okay.
It's,
It seems like a lot of yeses. I wouldn't have proposed that 80% of employers in Ontario actually have something that would meet a standard of an adequate return to work program.
But it's not employers, it's workers.
no, this is employers that report.
No, but your measure of observation isn't an employer, it's a worker.
Yeah. So at the individual worker level.
So on the assumption that it's just for the sake of argument, it's one worker per employer, just for the sake of argument. I wouldn't have proposed that 80% of employers in Ontario have an adequate or optimal return to work program. So it's interesting. Would you?
Well, in my small business research, which is now getting quite dated, we found that small employers were quite successfully targeted by these firms that offer their services, will set you up with this plan to guarantee low claims. And so there's thriving industry out there offering those services. Doesn't mean they do it themselves, but they do.
But can I take firm size as an example? If we looked at the distribution of firm size in a claimant population, it would not look like the distribution of firm size in a workplace population. They would be different.
To be continued.
Okay.
So, there's one other explanation is that there's probably a lot of social desirability here. So, even there might be a number of firms that don't really have it, but they
Say they do.
say that they do. So you have to be quite courageous to actually say, no, I don't have it.
Are they asked, do they have a return to work program, or do they offer modified work?
I think that it's about the.
For sure they have modified work.
Yeah, because I think that's probably, I mean, almost every employer will fill in on the form saying they'll offer modified work because they know that they should,
Yeah.
right? So, to me, I'm not surprised at all that that's what they say.
So the fact that they report that they don't have it means that they might.
They really don't.
The other interesting thing here is that this is still coming into play for people who are off work at 4 weeks. So it's not just in the first 4 weeks where they aggressively go after getting people back. It's still important afterwards too.
Yeah. And in the end, this is the information that a case manager at the WSOP needs to work with.
Can I just ask a question? How do I read the coefficients, or if it is less than 1?
So this is larger than 1 means a faster end of benefits,
Okay.
and smaller than 1 means that it takes them longer to end their benefits. So if you don't have it, then it takes longer in the first episode to end your benefits.
So is that saying no opioids, you're slower?
I'm not there yet. Okay, so physical demands. So if you have manual, so this is again like without work relatedness. It shows up in more than 50% of our bootstrap models, so that's why it's retained. So it improves our overall model. And you could say that if you have manual work, it takes longer before you get back. And that's based on a classification that's actually available within the WSOP National Occupational Code. And you have to do a transformation or translation to actually categorize it into these factors. So opioids. So if you have any opioid prescription, so Andrea is helped us greatly in that. It slows down. So they have a slower. It takes longer before they have an end of benefits. And it's a very crude yes/no where we have the information is more detailed and we can actually go into more detail, but it doesn't make a difference in our estimate whether it's strong opioids, weak opioids. In the end, it's yes versus no. And then we have the functional abilities form. So that's a form that the healthcare provider, that's also something that we came up with based on stakeholder feedback. If a healthcare provider sends back a functional abilities form to the WSIB, it means that it predicts that people return to work faster. So, and the more the better, it seems. Our explanation is, well, if people don't plan to get back to work, it's very unlikely that a functional ability form will be sent in. So, and the more immediate the return to work is, the more forms will be sent in within that first 4-week time span. So it's really about the information in the first 4 weeks. So the moment they start communicating with the WSOP that somebody's ready to get back to work, they are more likely to end their benefits.
And Yvonne, just for my benefit, why would a provider submit more than one in the first 4 weeks because of a change?
It's supposed to communicate a change.
Okay. Okay.
And they get paid for every form.
Yeah.
And even regarding the OCAR description in the variables considered, it's black there. It doesn't fit in the categories of evidence.
This one.
No.
The black text.
The black text where you.
Yeah.
But there is evidence, and Nancy is doing the systematic review. Maybe it was not included in your.
Wasn't when we started.
Yeah, but there is. I don't know if you want to change the colors or the level of evidence, but there is evidence from other studies, 4 or 5, that Nancy is doing a systematic review, that they are factual.
So I think when we started, there were I found 2 or 3 studies that weren't particularly high quality, that showed some indication that there might be something going on, and that's why we included it. But so by now, the evidence is getting published.
I think there's 5 or 6.
Am I reading it correctly that 136 people did not receive opioids?
They did. Any opioid prescription.
Any opioid.
136.
Oh, it's the second part of that. Okay. Yeah, it was. Okay.
10%.
Yeah.
Had an opioid bill at the WSIB.
Yeah. That's another one, because there might be. Yeah, there might be people that have another source of getting their prescription paid for. So these are the people that actually get their prescription paid by them.
For everyone that WSIB pays, the private insurance is probably paid by like 3 or 4 workers.
Yeah.
Not billed to WSIB.
So this might be a special group that has to rely on the WSIB to get their opioids. Of course, the stakeholders were very interested whether being in a program of care actually mattered, and it does. If they get people back to work, if they get into the program of care within the first 4 weeks, which is, I think, the aim of the WSIB, they do get back to work a little bit faster. So,
Just can you remind me what the time period is?
so the first 4, it's all the information that the group would collect in the first 4 weeks, and
2005.
yeah.
2005.
Yeah.
Same as the Readiness for Return to Work cohort.
Yeah. Okay. Thank you.
So how well does that fit? So the first step we looked at, if we just use the info that was available in the claim file, so stuff that we can pull from the system. If we would only use that information, we would get an area under the curve of 0.67 or a C-statistic of 0.67. And according to our classification, that would be considered a poor fitting model. So just relying on the claim file wouldn't have gotten us very far. So then we added the model that we added the data that we entered from the form. So it's available at the WSIB. But we have to do the data entry part. And so we got to an area under the curve of 0.71, which is considered to be fair. And so it did make a difference. It helped us to actually take that second step. And we got to a model that has a fair fit. So what does that mean? So if we split people into 2 groups based on the score on their prediction rule, you actually find that people that return, so this is the people that return to work slowest, and this is the 10% that return to work fastest. If you look at the graph, don't have to be a statistician to interpret this. It does take quite a bit longer for people in the worst 10% to actually get back to work during the follow-up of 2 years. So eyeballing it, the difference seems quite substantial, even though we were not totally happy with the model fit that we achieved. So it means that the 10% worst they return to work, but the best 10%, so the ones with the lowest risk score, actually return to work almost 4 times as fast as the ones that had the slowest recovery. I'm going to the next slide because what we know is that people have a lot of trouble actually interpreting hazard rate ratios. So what does that mean? So if you're in the worst group, at 6 months, 41% is still on benefits, 59% is off benefits. And if you're in the best group, 4% at 6 months is still on benefits, and 96% has ended benefits. And at 2 years, for the worst, it's 25% are still on benefits, and 70% is off benefits. So what you can see is that it's not a perfect model, because these 1% were actually categorized as being the lowest risk, but they're still on benefits. So it's not a perfect fitting model in that sense. But it does give you an overview of what those hazard ratios actually mean. So if you look at the characteristics that are in that model, what does that mean? So the worst 10%, 11% actually had a program of care in the first 4 weeks, and the best 10%, 35% had a program of care. The hazard rate ratio was not overwhelming, so this kind of points in that direction as well. So the worst 10% did not have a functional ability form in those first 4 weeks, where the best 10%, 86%, did have a functional abilities form sent in the first 4 weeks. And for having a return to work program in the workplace, the worst 10%, of the worst 10%, 9% of that 10% had a return to work program in the workplace, and of the best 10%, 99% had a return to work program. Of course, I like return to work programs and workplace accommodations. It's really interesting. Probably if I would put the opioids column in there, it would probably be similar to the numbers you get for the return to work program.
Through the functionalities form, does that mean that if you get more doctors to fill in forms, there's a better chance of people returning to work faster?
No, maybe. Let's try. Let's randomize and have one group send in as many forms as they can. No, but it's an indicator. So there's a whole process underlying it, and we're not explaining a lot about the process. We can only guess about what's going on. But it's an indicator that probably has utility for this problem. So that's again the predictive aim versus the explanatory aim. You probably need other research to explain what's actually going on, but it's an indicator for something else. So the final step, what we did was get in the data that we got from the Readiness for Return to Work cohort that uses a lot of well-validated questionnaires. In the end, only 130 people. Shouldn't say only, because if I look at comparable studies, they actually have a very similar number of subjects in their study and to do this kind of work. So what we first did was, do people in the Readiness for Return to Work study that are still on full benefits at 4 weeks, are they comparable to our bigger sample, our 1,400 cases? So what we did was we fitted the model that we got from, so the risk score that we got from the larger sample, and fitted it in the smaller sample. So it's in a sense it's sort of validating what we found in the smaller sample, and we found a very similar area under the curve. So it doesn't seem like they are very different from the larger sample, because the model fit is actually quite similar. What we did next was, so the score that they got from the prediction rule, so that using all the available information that we had at the WSIB, and trying to explore which extra question we need to ask to get to a better fitting model. So does the WSIB need to ask about pain? Do they need to ask about functional status? Do they need to ask about depression, or something else that they might want to consider? So we wanted to see whether adding those variables to the model, whether that would actually improve our model. So this is then the hazard rate ratio of the predictions rule score that we derived from the larger sample. And in the end, it seems that adding a 10-point fast scale actually improves your model. And if we then calculate the model fit, we actually get an area under the curve of 0.88, which can be classified as having a good fit. It's almost reaching an excellent level.
And Yvonne, this validation is done on the Readiness for Return to Work cohort, where cohort members responded to a survey in which functional disability, pain, and depression was measured by self-report.
Yeah.
Okay.
Very good. So the pain score is a very simple 10-point fast scale. So it's a little line where they have to say how much pain they have at that moment. The practice. So in a way, it's kind of interesting because the functional status score is a 26 items, and the depression score is TSD. How much? 13.
30.
So that has a lot of items. Yeah. Okay. And so in that sense, it's just one simple ruler asking people about how much pain they have. It's quite interesting that it's such a simple addition.
Was that pain right now, or pain since your injury, or the combination of both of them?
I think it's pain right now that I...
Okay, and that would be around the 1 month mark when they answered that too.
Yeah, because that's another point, is that question, the surveys were sent out, and most of those surveys came back 4 weeks after first day of injury. So it actually coincides with that 4-week mark. Okay, the recurrences, because I told you that not a lot of people looked at recurrences, so there wasn't a lot of literature we could actually base our variable selection on. So we considered the 25 factors that we also considered for the first episode. 17 actually had an association of 0.2. So there are some people that it's a little bit all over the map if you look at the research into recurrences. So it's highly dependent on which factor you take into account in your model. So in the end, these are the ones that ended up in more than 50% of our model. So after that bootstrap validation step, so it's so age and gender were forced into the model because we always want to adjust for age and gender. Didn't seem to matter age if you look at statistical significance. Gender did seem to matter. Physical demands was in over 70% of the model, so that does seem to matter. And having a manual job does seem to increase the hard. You get a quicker. It takes less time to get that recurrence. Again, opioid prescription was retained in the model. And the functional abilities, having a functional ability form also was retained in the model. This is a bit odd, of course, because it helps you to get back to work and also helps you to get a faster recurrence. So it's,
Can I just check one thing here? Am I right that the exposure time at risk of a recurrence for people who go back to work early, that their exposure time is greater than people who, in their first episode of disability, are away from work for a longer time?
Yeah.
Right. So perhaps what you're seeing with the functional ability form finding is a bit of an artifact of that?
Well, because what was also forced in the model was the episode length. So the length of the first episode. So what I was expecting and what David also was expecting, or what we all were expecting, that if people would be rushed back to work, so they would be back really fast, that they would have that it would take less time to actually get a recurrence. But it did in the end in that model it didn't seem to matter. But so this is all, especially this one is a bit puzzling. and it's not surprising that it's all a little bit murky because the model fit of our recurrences model is quite poor. So it's all around 0.6. So that's really an area that we need to explore. We already knew that we needed to pay some attention to it, and this exercise actually shows that we don't really know a lot about what causes recurrence. I just read a study from Washington where they said that it might actually be fear avoidance belief, so it's more the psychological interpretation of low back pain. But that's the first time I saw that, so we really need to look into what causes people to have a recurrence. The other thing is that I actually think that sometimes a recurrence isn't always a bad thing. So if somebody attempts to get back to work, we shouldn't, and it doesn't work out, I don't think we should necessarily interpret that as a failure. It could actually be a part of a process that actually gets people back.
Isn't it possible to look at recurrences not according to individual traits, but according to traits of the workplace or the work sector? For instance, an organization, how many recurrences happen per organization, that sort of thing?
Not in this design, I think, but
This is very much based on the individual.
Yeah, so you're going to find individual issues.
So how do we compare? So I said, well, it's not good enough, blah, blah. So this is the R-RTW scale. It's developed by Stephen Linton. Sometimes it's also called the Linton-Halden screening questionnaire. In Sweden, they report it's 0.81. There's a lady, Rhonda Kirkwood, that did her PhD thesis at McMaster's, that studied it in a workers' compensation setting in New Brunswick, because apparently there's quite a few workers' comp boards that actually use this particular screening questionnaire. And she actually found the area under the curve was only 0.69. So it is dependent on the setting. Another now quite famous tool is the StartBack screening tool that was validated that was developed in the UK, tested in a randomized controlled trial, and showed that it actually improved care for people with low back pain. And they said that they had a similar, in the end they didn't, in the paper they don't really report their area under the curve. They say it's similar to the R-RTW, which before they had the Lancet publication was quite the recommendation to start using the tool. Now it would be the other way around. We would say, well, it's just as good as the StartBack tool because they're now more or less the gold standard. And a colleague of mine did a study and we developed a prognostic tool based on a lot of validated questionnaires and found an area under the curve of 0.61. So in that sense, we're not doing that bad. So what would be the next step? So we did the derivation, we did part of the validation. I might want to do it in a slightly different setting or in a newer population because 2005 is kind of old by now. And what would be really nice would actually get the opportunity to do an impact analysis. So how does it change behavior of the user and does it improve outcomes or reduce costs? This is how Jonathan Hill and colleagues did it in the UK. They have this screening tool, and they, based on the score, they divide people up in low risk, medium risk, and high risk. And based on their risk score, they get a particular kind of intervention. And they found that it actually improved outcomes in low back pain patients and reduced costs. This morning, because I was wondering about their work outcomes, because in the design paper they said that they had work outcomes. So I sent them an email. I said, so what's happening with the work outcomes? And they said, well, we're not really planning on publishing those.
oh dear, let's do that.
So I think there might be a little bit of publication bias going on, that they weren't that exciting. But they did it. I think they're the only one that actually did the impact analysis of their prediction.
Did they register that? I'll go ahead.
The screening tools are all about the individual.
Yeah.
How about screening tools for employers? Like that, because some of the characters you had in the original things were about employer characteristics without a return to work program, and wondering which factors are more critical in terms of to making the difference. And I was also wondering, we don't know whether these people return to either the employer or elsewhere.
Oh, would be nice. We I sent in a proposal to CHR, and we're still waiting for it. We got the recommendation that the review panel is recommending that they should fund our study, and in that proposal we actually said, well, let's go beyond the end of benefits and look at worker relevant outcomes and see if they actually really return to work, or any work, or similar work, or better work, or worse work. So, okay, well, this was the discussion, and so only,
Also, this is all characteristics up to now have been characteristics within the first 4 weeks.
Yeah.
Have you thought about looking at things that evolve after that, like even if they have a permanent impairment or something like that, that would obviously surface on the data?
we could do that. Still have to get this out. And of course the numbers are getting smaller then, but then if your outcome is permanent impairment versus those, then that would be an option.
Not as an outcome, but as a predictor.
Yeah. Yeah, but the permanent impairment is the fun. So you get a permanent impairment how many months after your daily injury? So then it's the chicken and the egg. Yeah. So is it the permanent impairment, or is it an outcome, or is it a predictor?
Why don't we let Ivan wrap up, and then we'll see if we have time for another question.
In the end, there's an app for that. So we had to buy a little gizmo to actually. Which one do I have to plug in there? I can already start doing this.
I just came all this way for the app.
Okay. Oh, you need the. Well, this is the unofficial part, anyways. So nowadays, if you go into the Apple the App Store, then there's all these screening tools. I can actually go back and show you which one I found so far. We actually got money from Manitoba to make an inventory of what's out there and what you can actually all. So I went on the Apple iStore, of the App Store. I just got an iPad, so I'm not really into that whole jargon. So the Start Back tool is actually an Apple app. The R-RTW questionnaire is an Apple app, and then there's two other ones that are totally unvalidated, but very interesting. Because the last one actually looks a lot like the profile that I got in one of our studies. But so this is the Start Back tool, and they give a big disclaimer because they don't. People are going to use this on an individual. If you have back pain, you're at home and you're trying to find information. End up in the App Store and then download this. You pay $2.99 actually for this app, and then you get all this information. So this is actually 9. Start Back tool is a 9-item questionnaire where you have to answer simple yes no. Yeah, well, and so worrying thoughts. Terrible, it's never going to get any better, so there's psychosocial stuff going on. I have not enjoyed all the things I used to enjoy. Bothersomeness of the back pain, which this group is actually famous for. So, and then you show the results. In this case, I'm medium risk, so I would probably be sent to physiotherapy and do an exercise program. Diagram, it's cool. And then I could submit it, send it to my physician and say, well, I did this screening thing and I should actually get physiotherapy. So there's a number of them out there. So this one is actually well researched in a UK setting. Jonathan Hill told me that actually they tried it in Denmark and it doesn't seem to work as well for Danish people. So I'm not sure if, the App Store is worldwide, but it might not actually apply to a Canadian setting. So it would be interesting to actually,
And they're looking at back pain and primary care as
Yeah.
opposed to other tools, right?
Yeah.
Not necessarily work disability.
yeah, I like what Rhonda Kirkwood found, where the Örebro scale in Sweden is a quite nice scale. In New Zealand, it seemed to perform quite well, but then she looked in New Brunswick and it didn't seem to fit very well. So. It's 12 o'clock, so I'm wrapping up. So I think we had a lot of questions. If anybody has any other questions, feel free to come forward and ask them. I think we can give people the opportunity to actually get back to lunch.
Thank you, Yvonne. Thank you.